Hi, my name is Manjiri Dighe. I'm from the University of Washington, and my lecture topic today is thyroid elastography. So palpation is an important diagnostic tool, and it was practiced as early as in the 2600 BC by the Egyptian physicians. It's said that it's a business of the physician to know, in the first place, things that are similar and dissimilar, and that are perceived by sight, touch, and hearing, and this was by Hippocrates himself. So what he mentioned was that such swellings as are soft or free from pain and yield to the finger are less dangerous than the others that are hard or palpated as hard and large and indicate danger of speedy death. So perhaps he was talking about cancers. So what's the principle of palpation? When you have a focal mass and you press on it, if the mass is soft, it gets deformed by pressure. But if the mass is hard, then it's not deformed by pressure and is palpable. So stress is basically higher on fingers when you're palpating something overlying a superficial and a hard lesion, and lower on the receptors when they're surrounding softer surrounding tissues as well. So the tissue motion studies were done in the 1970s and early 1980s. Sonoelasticity term was coined in 1988, and it was basically using Doppler ultrasound to detect motion in response to external vibration. Ophir in 1990 developed a quantitative method for imaging elasticity, and that was called as elastography. So it was based on external compression. There was cross-correlation analysis of the pre- and post-compression A-line pairs to decide if a lesion underwent deformation or not. So it was mainly developed for breast imaging. But why use it in the thyroid? Because thyroid is a very superficial organ, mostly, a few centimeters deep or less than that. Also, you have these two structures adjacent to the thyroid, the carotid artery, which can help in compression on the thyroid itself. And at some points, it does act as a cause for artifacts. And also, the thyroid can be compressed against the trachea, which acts as a hard area. But what's the problem? Well, the problem is that you have these thyroid nodules that are increasing in incidence every day. And that's because of increasing use of imaging, where they're detected as incidentalomas. So if you look at this chart, if you palpate on palpation, you have an incidence of about 5% of thyroid nodules detected. In autopsy, the number is higher. About 60% of patients have nodules. On ultrasound, almost 50% of the population would have some thyroid nodules detected. But the malignancy rate is pretty low. Out of those detected, only about 10 to 15% will actually have malignancy. Now, fine needle aspiration is a standard procedure. It is, of course, an invasive procedure, and can lead to inadequate samples in about 10 to 20% of cases, which itself leads to quite a lot of problems, which is rebiopsy or even surgery at some times. So the first study essentially was done by Andrei Lishchik in this paper described in Radiology, where he had 52 nodules on 31 patients. They did real-time elastography and did offline analysis of the elastograms. They also did ex vivo biomechanical testing of these tissue samples and found that papillary carcinoma was stiffer than normal or benign lesions. They calculated something called a strain index value, which, if greater than 4, was a strong indicator of malignancy with a sensitivity of 96% and specificity of 82%. Essentially, there are two types of techniques described, strain and shear-wave. In strain elastography, manual compression is used, which is a most commonly used technique for strain elastography. And then the pros of the strain elastography are that it's widely available, it gives good results. Cons, of course, are that you need someone who's trained in doing strain elastography. The changes in amplitude and velocity of compression affect the strain. You may cause pre-strain compression itself, where you press on the lesion before actually applying compression, and then some other things like carotid artery pulsations can interfere with the results. Histology of the nodule can be misleading as well, and that's true for both shear-wave and strain elastography, when cytopathology results may not correlate with the imaging itself. Now, in shear-wave elastography, the shear waves are generated by the machine, so there's less variability. Unfortunately, there are a smaller number of studies with shear-wave elastography, and if you have a lesion which is located very superficial, like in the isthmus, shear-wave can cause artifacts. Large nodule sizes cannot be assessed because of less penetrability, especially greater than 3 centimeters. And then cystic components are a problem with shear and strain elastography as well. Now in strain elastography, the technique detects local deformation, that is strain, under some slight pressure, which is usually by the hand. Compression is performed by the transducer or some physiologic movement like carotid pulsation. What is produced is a color-coded elastogram superimposed on the B-mode image. Now this is an example of the carotid compressing. As the carotid increases in size, it compresses the thyroid in the transverse direction and increases in the AP dimension. This is an example of color-coded images produced by elastography, and you can see that they range from soft to hard with different color coding used from red to blue, as in this particular case. In terms of strain elastography, there are two kinds of elasticity assessment: either visual scoring of color, that is color-based elastograms with 4 or 5 scale scoring systems. For example, in this case, 5 scoring systems were used, so score 1 to score 5, right from blue to green with increasing amounts of green as we go towards the softer lesions and increasing amount of blue towards harder lesions. This is an example. So here's a normal thyroid. As seen on the B-mode elastograms, we see no nodules in the thyroid, and the color elastogram shows a similar thing with uniform green within the thyroid. The trachea appears blue because it is stiff. So that's a normal thyroid. This is a patient who has a lesion which has a mixture of colors in it: red, blue, and green. It is a solid cystic lesion on ultrasound with vascularity within the solid components, and this would be something which is stiffer lesion, perhaps in the 4 or the 5, and this was a papillary carcinoma. This particular lesion has a mixture of both blue and green in both these cases, but this upper lesion turned out to be a follicular carcinoma, a follicular lesion, and the lower lesion turned out to be a multinodular goiter. Now, qualitative assessment is very difficult, and people have come out with quantitative assessment using something called a strain ratio calculation, where 2 ROIs are placed, one over the target region, which is the thyroid nodule in this particular case, and the other over an adjacent reference region, which in the thyroid is surrounding normal thyroid, as seen in this example. As the strain ratio increases, that suggests increased likelihood of malignancy. Strain can also be induced by carotid pulsations. In this particular technique, no freehand compression is applied. It is less operator dependent because you just rely on the carotid pulsating and causing compression on the thyroid. It is also less operator dependent and because it gives uniform pulsations or compressions on the thyroid with each systole in the flow in the carotid. Now, qualitative and semi-quantitative strain ratio computation can be performed in case of strain-induced carotid pulsation elastography as well. So this is an example. This is our study where we did where we calculated the thyroid stiffness index, which is the strain near the carotid artery divided by the strain in the thyroid nodule. And the higher the TSI, as we called it, indicated a stiffer lesion. So these are examples. This is a lesion you can see on B mode that has both solid and cystic areas in it. The TSI was about 17.4, and on histopathology was a nodular goiter. This is a lesion which is more uniform, more isoechoic, with no cystic lesions in it or calcifications in it. The TSI is a little higher, 26.5. This was a nodular goiter with interstitial fibrosis. Lesion with microcalcifications and hypoechoic appearance, solid. TSI of 31.4. This was papillary carcinoma. And then this was a hypoechoic nodule, but with a low TSI of 6.95, which was a colloid nodule. So when you take all of these results together, normal thyroid and papillary carcinoma were distinguishable from other lesions, and the TSI for papillary carcinoma is higher than the TSI for other lesions, and even the normal thyroid, as can be seen here, where papillary carcinoma is much stiffer compared to these other lesions. This is a typical example. This was a patient who was being followed up for 2 nodules, one lesion in the upper pole, one lesion in the lower pole. Patient was being followed up for growth in these lesions, and you can see that on the thyroid elastography, The TSI in the upper pole lesion was 16.8, but in the lower pole lesion was 41.15. With that high stiffness value, we suggested fine needle aspiration. This came back as papillary carcinoma. Histopathology confirmed the upper pole lesion as being nodular goiter and the lower pole lesion being solid papillary carcinoma. So these are the studies that have been performed, some of them in thyroid elastography, and you can see that the sensitivity and specificity is quite high, reaching almost 100% specificity, range of specificity as such, and then sensitivity in the high 80s as well. This is a timeline showing some meta-analysis that have been done. This particular one done by Buchanga shows 639 nodules evaluated with strain elastography and sensitivity of 92% and specificity of 90%. In 2012, then Moon did a retrospective study of 703 nodules with elastography sensitivity of 65%, negative predictive value of 79%. But when they added the grayscale ultrasound features, the sensitivity increased and negative predictive value increased as well. Same year, this particular group suggested that ultrasound elastography is not superior to grayscale ultrasound in predicting malignancy. They had 237 thyroid nodules that reported lower performance with elastography in comparison with grayscale ultrasound. However, in 2013, Azizi did a prospective study using a 4th grade elasticity score with almost 1,000 nodules and found that they had a positive predictive value of 36%, negative predictive value of 97%, which was this positive predictive value was higher than for microcalcifications alone or hypoechogenicity alone. So that's significant. Lastly, Razavi looked at meta-analysis of 24 studies with 3,531 nodules and saw that the sensitivity of elasticity score was 82%, specificity was 82% as well, and found that ultrasound elastography increased the ultrasound accuracy. So in terms of strain ratio, these are the studies that have looked at strain ratio with sensitivity ranging from 100% to about 43% or so, and specificity in the high 70s. Moving on to Shear-wave imaging of the thyroid. This is a new technique. Shear-wave technique uses these shear waves that are generated by the transducer that displaces tissues. Use an ultrafast scanner with a frame rate of almost 20 kilohertz that receives the information back, and a map of the shear wave is created. So this image over here shows the shear wave. This is at 2 milliseconds. Then at 3 milliseconds, as it is continuing to displace tissues laterally and spread laterally. This is at 4 milliseconds and 5 milliseconds, and you can see those two visible parts of the shear wave. Finally, an image of the shear wave speed is calculated and created and displayed for us to see. So this is just again showing how shear waves are calculated from volumetric force creation to ultrafast imaging and then image acquisition and processing. This is what is typically shown, a color-coded map of the lesion with the color images ranging from blue to red, typically blue indicating soft, red indicating stiff. So it's a new technique. There are fewer studies performed, but it is a quantitative technique of assessing the thyroid nodules. This is an example of a case study, case courtesy from Dr. Masciotra from Italy, and what he shows is there's a lesion in the thyroid nodule with a mean stiffness of 20 kilopascals, 20.8 kilopascals. This was a benign nodule and basically a colloid nodule. On ultrasound, you can see that it's a mixed solid cystic nodule with no flow in it. However, this particular patient is again a 51-year-old woman. She has two small nodules in her left lobe. This is the upper pole nodule and this is the isthmus nodule. And what you can see is when you look at the stiffness in this particular lesion, in the lower pole nodule, the stiffness was lower, about 31 to 33 for a mean, but the paraisthmic lesion had high stiffness in it as seen on the color image, and then the mean stiffness was about 58 to 72 kilopascals. FNA of this paraisthmic lesion was performed, and that came back as papillary carcinoma. So these are some studies performed with shear wave imaging, and again you can see some of these are meta-analysis, but the number of nodules and the sensitivity and specificity are all over the place. I think it's because a new technique, and it's still in evolution. These are some studies. This particular one, Lin from China, shows that sensitivity of 84% and specificity of 88% with a good negative predictive value of almost 99%. This particular study shows, again, similar things, good sensitivity and specificity. If you do find that the stiffness is high, the positive likelihood ratio was about 7.4 according to them, and they had a good area under the curve as well. So here's some examples. This is a patient who has a strain elastography performed. There's so the lesion here is solid. You can see the lesion on with a color overlay image. The TSI in this particular case was 20.2. This turned out to be a nodular goiter. This particular lesion, large lesion, very irregular, but the TSI and the color map shows that it's lower stiffness, TSI of 9.9, and still turned out to be a papillary carcinoma. So there's a disconnect over here. Lesion with a higher TSI turned out to be benign. Lesion with a lower TSI turned out to be papillary carcinoma. So these are some pitfalls of strain elastography. Similar thing in shear-wave elastography as well. Two lesions, one lesion with a high stiffness value of 76.7 kilopascals, another lesion in the same patient with a stiffness value of 21 kilopascals. But still, these two lesions both turned out to be papillary carcinoma. So here's a lesion, large lesion. When you look at the color image, it does have some high stiffness areas in it. Maximum kilopascal value of 126.9, but the fine needle aspiration showed a follicular lesion with Hürthle cell changes. The cytopathology said could not exclude neoplasia, and so the patient was operated on, a hemithyroidectomy done, which showed that this was a nodular hyperplasia, multinodular goiter with a background of lymphocytic thyroiditis. So now to talk about some of the artifacts in elastography. Some of the artifacts are related to the nodule characteristics itself and some to the elastography technique. In terms of elastography technique, when you have deeper lesions, you can have lack of penetration and absence of information. If you set the color scale incorrectly, you can always have a near field artifact in the closest region, and then the same area you'll have a compression artifact as well. In addition, you can have compression artifact from carotid artery pulsation. Some of the nodule characteristics which can cause artifacts and that need to be recognized are when you have a cystic and solid lesion, when you have rim calcified nodules which may not transmit the compression, and then you have a large nodule when the compression may not be transmitted all the way deep into the lesion. So this is an example of near field artifact where you have the reddish areas and transmission of all the high stiffness color through the lesion right up to the trachea. And this was an isthmic lesion. You can see that it's very close to the transducer. Now, if we used a standoff pad and then took the measurements again, you can see that we avoided this near field artifact. Sometimes you have compression artifact, and these are seen as finger-like projections, and that's because of the transducer being placed too hard on the neck, causing a compression artifact on the neck. It's on the thyroid nodule and the neck. And another way to recognize this is that it extends through the image, suggesting that it is a compression artifact. This is an example again showing the effect of compression. This particular image was acquired without compression. This particular image was acquired with compression. And you can see that the strain ratio, the strain changed. Here the maximum kilopascal value in the surrounding thyroid is 9.2, with in the lesion about 16 kilopascals. With compression, it changed to maximum of 14.5 in the thyroid, normal thyroid, and a maximum of 18.8 in the nodule itself. So you can have variability in kilopascal values even on shear wave with compression. When you use a strain ratio, now the strain ratio did not change as much. Without compression 0.5, with compression 0.7. So it may be better to use a strain ratio even on shear-wave elastography than absolute strain values. This is an example of color gain being set incorrectly when you have overgain, and you can see these reddish areas distributed through the lesion. Those are artifacts because of overgain and the color being set too high. Similarly, on undergain, you'll have areas that do not show any color, and in this case, increasing the color gain on elastography would be helpful. This is an example of lack of adequate contact, where you can see even on B mode image, there's lack of information along the lateral aspect of the nodule. So in this particular area, everything's black because there's no information with ultrasound. Similarly, there's no information with elastography as well. This can be avoided by making sure that the shear wave box is within the central part of the nodule and not off to the side, and with good contact, and a good contact is maintained with the nodule and the surface. This is an example showing artifact due to cystic areas in the nodule. On B mode elastogram, you can see that there are cystic areas here superficially with solid areas deeper. This shows high stiffness values posterior to the cystic area, so you can see reddish color beyond the fluid, and that is due to the shear wave speed being affected by the fluid portions of the nodule compared to the solid portions itself. This is an example showing lack of penetration in deeper nodules where the lesion is located more than 3 centimeters and there's lack of information on elastography because of the deeper location of the nodule. Calcified nodules can not transmit the ultrasound waves, and so you can see lack of information here, where you can see the calcifications, rim calcifications on B mode image, causing lack of shear wave information in that same region. Similarly, a rim calcified lesion shows lack of information on the shear wave elastogram images as well. So in reality, no surgery will be performed without fine needle aspiration. If malignant features are seen on ultrasound, fine needle aspiration would be performed for those lesions, and it may be more prudent to exclude benign lesions with elastography rather than trying to diagnose malignancy. And the question remains, what happens with indeterminate or non-diagnostic samples, in which case you might need elastography and fine needle aspiration to give complementary information. So can elastography help? Yes, it can. Of course, more studies are needed, more prospective studies are needed. It is also prudent to use carefully with common sense in terms of how the images are acquired and recognizing artifacts as well. So robust techniques are needed with better guidelines and more experience, and that can help elastography help us with fine needle aspiration in the thyroid nodules. Thank you.